and gentlemen. My name is Mark Dragosi. Okay, sorry. So good afternoon, ladies and gentlemen. You're welcome to this session, which will be more on medications and the role of the pharmacist in managing preeclampsia. My name is Mark Dragosi. I'm a pharmacist. I'm the head of pharmacy at the International Maritime Hospital. I'm also a clinical pharmacy specialist, more of cardiac and cardiovascular critical care medicine. I teach at the university as well, the pharmacy school. I have residents, I have fellows that I train at the hospital. And I do train some residents from the US as well. So I do quite a few things. We do have a very active maternity unit or ops and gynae unit, which we actively participate in the care of the patients. So this will be more of interactive. I won't make it like a classroom lecture. So feel free to relax and be able to speak out, and we're just discussing stuff. It's not like a teaching class. So I hope we will all loosen up and be able to contribute. I hope that's fine, right? So usually I don't, please. Looks like it's central, but can we do something about it? Try freezing in the... Okay. So they are calling the technical people. I think you can hide by the wall because the vents are this way. Okay. So just to maybe make us relax a little bit, I'd like to know where everybody's coming from, who you are, if you're a physician, nurse, lab, from pharmacy, students, whatever. Just something so that we know who is here. Usually I like to tailor my discussions to who is in the room and the audience. And if we have some people online as well, so that we are able to share the right information. So maybe we can start from you, sir. Who you are and where you're from.
Okay. My name is Robert Ansem. I'm a registered general nurse and a student physician assistant, also regional coordinator of APEC, Upper East Region.
Thank you.
My name is Gertrude Selassie Amedio. I'm a physician assistant at Airport Women's Hospital.
Thank you.
My name is Abering Appel. I'm a midwife at Airport Women's Hospital.
Thank you.
I'm Esther Jukanida Benefo. I'm a midwife at Adabraka Polyclinic.
Adrena Okwe, Rich Hospital.
Thank you.
I'm Dr. Ludger Dako. I'm an obstetrician gynecologist at Egon German Clinic.
Thank you.
Nimrod Mohammed, the Noguchi Memorial Institute, a research assistant.
Thank you.
Julius Ohenebe Frifa, research assistant, Noguchi Memorial Institute for Medical Research.
Okay, thank you.
I'm Linda Anna. I'm a midwife at Rich Hospital.
Okay, thank you.
My name is Gertrude Amegashi. Yeah, I'm a midwife too. Get to South Municipal Hospital, Apalauton.
Wow, very far away.
Okay, Dr. Simon Agbevadi, OBGY Trust Hospital.
Okay, thank you.
Dr. Isaac Entry, obstetrician gynecologist, Holy Family Hospital, Nkoko.
Thank you. You too far away small.
Dr. Samuel Edu, obstetrician gynecologist, St. Michael Hospital, Bramso, Kumasi.
Okay, thank you. Welcome, sir.
Florence Afarewedu, Greater Accra Regional Hospital, midwife.
Thank you.
I'm Sarah Baining, a midwife at Pantine Psychiatric Hospital.
I'm Philomena Jelu Armstrong, midwife, Pantine Hospital.
Comfort Mensah, midwife, Rich Hospital.
Thank you.
I'm Efia Sechi, resident, OBJY, Whole Teaching Hospital.
Thank you.
I'm Fiona Santwa, midwife at Ridge Hospital.
Thank you.
I'm Laurentia Mensah, midwife at Ridge Hospital.
Thank you.
I'm Sabine Eidu, midwife, Ridge Hospital.
I'm Millicent Edujemfi, midwife, Ridge Hospital.
Looks like Ridge Hospital has taken over this place.
Genevieve Owusu, critical care nurse, Ridge Hospital.
Thank you. So you're like my sister.
And then Dr. Ayn, physician and research fellow from the Netherlands.
Thank you. Welcome, sir. So you're all welcome. So this is going to be very interactive. For those of you who came in a little late, my name is Dr. Makwame Dradosi. I'm a clinical pharmacy specialist, lecturer, and I'll be moderating this session. I'll be facilitating this session. We do have a lot of specialists here, so I feel like I could invite them to come and teach, but well, since we are talking pharmacy, we'll discuss what we know. I believe some of our colleagues have discussed the guidelines, so I won't go so deep into it, but I still have them as part of my presentation. We'll try not to duplicate many things. So with your permission, sir, can we go? All right. All right, so objectives. For today's outline, we'll be looking at the reason why we are here, introduction, a few key points, hypertensive disorders in pregnancy, which I believe have been spelled out elsewhere, and then the management of hypertensive disorders. We'll look at a couple guidelines, the NICE guidelines, and then the US guidelines, and then we'll look at what we have in Ghana, if we are doing top-notch stuff or we need to upgrade ourselves. We'll look at some medications. We'll look at what we can use, what is not safe to use in pregnancy, and then challenges in the care of our patients. We do have a lot of, especially the nurses, the obs and gynae physicians, they can actually tell us some of the issues we have nationally, globally, that are impeding effective care for our obs and gynae or preeclampsia patients. And then we'll look at the obstetrics pharmacists, what we can do to support our doctors, our nurses, our PAs, and then a few closing comments. As we go along, it will be quite interactive. I won't just be talking, so please make yourself available to comment as and when needed. So after completing this activity, we should be able to look at the different classifications of hypertensive disorders in pregnancy, recognized medication options that we use to treat disorders in pregnancy, especially preeclampsia and chronic hypertension. I appreciate principles of drug use and prescribing in maternal health. So what we should consider before giving out medications, before writing prescriptions, patient assessment, and other things. And then identifying challenges in the management of preeclampsia, and then describe the pharmacist's role. So before we start, even what are your expectations for coming in here? You can maybe just a couple comments from people. And what do you expect after we're done with this? What do you expect to take home from here? Anyone? All right, so then I'll ask the next one. We have so many guidelines that we use to determine what is proper BP ranges for our patients. What do we use in our clinical settings? I'm talking about your hospital. Somebody comes, what do you use as a yardstick to say this person has preeclampsia or this person has chronic hypertension? First, normal adults, then the next one is our pregnant women. should we start from Rich? Since you are the many here, you can have a caucus and tell us. Anyone from Rich Hospital? I know you have your protocols. I've been there.
The normal BP is a BP of a systolic of below 140 and diastolic of below 90.
Thank you.
Thank you.
And like my former preceptor would say, from which guideline? But we'll talk about that later. So do we all agree that that is what we use in Ghana? I'm sure later our obs and gynae doctors will come and say, we know something from somewhere else. Or do you guys have anything from anything else, any contrary guidelines that say anything otherwise for a pregnant woman? All right, we'll look at that as we get along. So a few definitions. Since we are all in the obs and gynae world, I believe we know what preeclampsia is, right? So I should skip it and go. But basically, it's the development of hypertension 20 weeks or after 20 weeks of gestation. So after they get pregnant, key word is 20 weeks. So that one I'm sure we know. And then they typically will be accompanied by proteinuria, acute kidney injury, or liver injury, with or without upper right quadrant epigastric abdominal pain. So these are things we all know from nursing school. We know from wherever we came from, our specialists and everything. So I won't spend too much time here. But I believe the nurses will agree with me, right? That's what it is. Okay. And then neurological complications such as blindness, stroke, or severe headaches may occur in severe cases. We'll look at that as well. And then there's also hematologic complications that typically we will see with these patients, which include breakdown of red blood cells, low platelet count, and then intravascular DIC, or disseminated intravascular coagulation, which leads to bleeding in certain patient populations. Then we have issues that can also affect the fetus or the unborn child, such as fetal growth restrictions, stillbirth, abdominal, umbilical, artery Doppler wavefront analysis, which may also be present in some of the patients. So these are key things that we have to take into consideration. When patients come, I always use one word. Time is life. Everything should be prioritized, and we should value like speed, 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 because without speed, we lose them. So these things, thinking of your feet and quickly looking out for some of these things can actually save a patient's life. Then further on, gestational hypertension appears. So this is somebody who doesn't have hypertension prior to getting pregnant, but after 20 weeks, they develop hypertension. BP starts going up. They've been coming to antenatal. Everything was fine, but then after 20 weeks, the BP starts rising. Then chronic or pre-existing hypertension, defined as somebody who had hypertension before they got pregnant, or prior to 20 weeks of gestation. And then there's also preeclampsia or eclampsia superimposed on chronic hypertension. So they had hypertension, they've been pregnant for 20 weeks. After 20 weeks, they develop preeclampsia, or you start seeing proteins, or you start developing kidney failure, liver failure, and some of the things we mentioned in the previous slides. So these are just normal definitions that most of us know here. Then eclampsia is the severe form of hypertension in pregnancy. I'm sure especially those of us in the maternity settings, we've seen some of these things before. It's one of the most serious complications of hypertension in pregnancy, because we lose a lot of patients because of it. Sometimes we catch them late. Sometimes they come in, we don't pay attention, or we miss the initial diagnosis, and then before we see, they are gone. But these are some of the things that we will say characterize preeclampsia. One, it's a new onset. I call it just a seizure. Somebody's pregnant, they come, they develop a seizure, start suspecting BP. So new onset tonic-clonic or focal or multifocal seizures in the absence of maybe any previous brain damage. There's nothing to show that they had any brain issues. All of a sudden they have seizures. Could be due to other things, or for one, brain damage or medication use. So if you do your screening with them and you check and you make sure it's not due to a drug, it's not due to any issues with the brain or any other thing, no history of seizures, and they develop a seizure during pregnancy, this could be a complication of severe hypertension or eclampsia. And then these seizures can progress to severe maternal hypoxia, which we know about, aspiration pneumonia, and trauma. So these are key things that we should watch out for in our patients. And then some of the patients who develop eclampsia may have CNS issues, memory issues, cognition, and they may be forgetful even immediately after. Some may have it at home, may recover, and then they come to you telling you that nowadays I feel like I'm forgetting things and like I'm not myself, blah, blah, blah. You should start suspecting some of these things. So here are our classifications. Some of these I've already described, but classification of hypertensive disorders in pregnancy, and this is from the US guideline. And they classify preeclampsia as hypertension and proteinuria greater than 300 milligrams per 24 hours after 20 weeks of gestation. And then they did also define preeclampsia as the severe form or the convulsive form of preeclampsia, which we just spoke about. Gestational hypertension induced after 20 weeks without proteinuria, and then chronic hypertension, BP greater than 140/90, pre-pregnancy or before 20 weeks, and then preeclampsia superimposed, which we've also described in the previous slides. So complications of preeclampsia are twofold. So these can affect both the baby and the mother. So we'll look at both sides. So for the maternal side, the mother's side, seizures can happen. For the child, intrauterine growth restriction, which basically the child doesn't attain their desired or recommended birth weight before delivery. Cerebral hemorrhage, which is common, which we all know about. Placental abruption, which I'm sure we know, our nurses, our doctors. Detachment of the placenta from the womb. Pulmonary edema, acute respiratory distress syndrome, so breathing problems, breathing issues. Disseminated intravascular coagulopathy, which typically would lead to severe bleeding in certain patients. And then HELP, HELLP, typically which stands for hemolysis, elevated liver enzymes, low platelets syndrome, liver hemorrhage, and rupture, which typically also manifest in some of our clients or some of our patients. And then thromboembolism, formation of blood clots. So DVTs, PEs in some of these patients. Cortical blindness without having any prior causes of or prior or eye diseases. And then laryngeal edema. So for the children, they can have intrauterine death, so they can die. And then iatrogenic preterm delivery, so delivery before 37 weeks. So these are some of the complications of preeclampsia. So what is the prevalence? The data I have here is more of like an average of some of the areas, but this is partly from WHO and then other areas. Hypertension in pregnancy can complicate about 10% of pregnancies. I'm sure it may be more in certain areas, it can be more in certain jurisdictions. But the question I ask is, in Ghana, what is our data? Has anybody done any study on it? Hypertension in pregnancy. Who has the Ghana data? Who knows how many of, approximately how many of our pregnant women have hypertension? So I found a few, and one of the studies said about 22.1% of mothers in Ghana have or develop hypertension during the period. There are PAs and our ops and gynae team. Can you confirm, has any of you done anything in your settings? Data on how many women, the pregnancy? Okay.
Please, recently I learned it's around 23%.
23?
Yes, please.
Okay, so that is quite close. 21.1 and 23, quite close. Anybody else? I'm thinking it's more. Or are we all just sure that we are competing with globally with like, or it's probably less?
This morning during the presentation, Dr. Fufie made mention of it. 2020, the EMONC survey that was conducted in Ghana, in his presentation, he made mention that the 23,000 women, who were pregnant, and the percentage was around 23, 22.
Okay. All right, thank you. So we are still around that area, which is, getting closer to the global statistics. So the third point, the prevalence of gestational hypertension in reproductive aged women is approximately 7.7. That is from WHO Global. So that is worldwide. So I think we may do better, or we can do better, let me put it that way, because we lose quite a lot of women daily from hypertension. So what are the risk factors for preeclampsia? One, first pregnancy. I'm sure this one too, they taught you in nursing school, the doctors look at it every day when they assess their patients. So first pregnancy, new partner or paternity, a new father, so that one, I was wondering how that would play into somebody getting preeclampsia or developing preeclampsia. And then younger than 18 or older than 35 years of age. So as and when we assess our patients, these things should come into mind. History of preeclampsia, a close family member or first degree relative, and then black race, so people like me and you, or people like our ladies of childbearing age. The risk is higher, obesity, BMI greater than 30, and then inter-pregnancy interval less than 2 years or longer than 10 years. So these are some of the risk factors for development of preeclampsia. And then what about medical conditions that can predispose our mothers to preeclampsia? One, so chronic hypertension. So if you've already had hypertension before getting pregnant, the risk goes higher, especially when the pregnancy is due to secondary factors, not primary hypertension. So any of the thyroid issues, your renal issues, pheochromocytoma, and other things. Pre-existing diabetes, that's type 1 and type 2. Those also can increase your risk. Renal diseases, systemic lupus erythematosus, so SLE, another higher risk for our mothers. And then obesity, we've mentioned obesity, BMI greater than 30. And then history of migraines, so people who develop a lot of headaches pre-pregnancy may also end up, that increases their risk of developing preeclampsia. Then thrombophilia, which is clotting easily. And then use of SSRIs, especially beyond the first trimester. So in our prescribing, we should probably be cautious of prescribing SSRI medications for depression or other conditions when patients present, especially beyond the first trimester. And SSRIs are selective serotonin reuptake inhibitors. So We use them to treat patients with depression. So diagnosis. One of the things I found whilst I was doing this was the fact that different continents and different jurisdictions have different numbers for diagnosing and for managing or treating the patients. And so I always ask, what do we use in Ghana, or where do we choose from? I was trained in the US, so sometimes I'm biased towards the US. Then I came to Ghana and realized that ESC, the UK, the Europeans also have something that is nice. So I had to now try and veer myself there. But then I ended up on the Standard Treatment Guideline Development Team for Ghana. And when we develop this thing, the fight is always like, which one do we choose? Europe says this, America says this, Canada says this, Australia says this. What about Ghana? So in Ghana, what do we use? How do we diagnose gestational or where are we? The doctors, I think this one, the doctors will help us. Where are we? Are we also 140/90 or 130/80 or in between? 140/90. Do we all agree? The rich people, you are the one that are many in the room. So if we don't consult you, you go on strike. We all agree. Okay. Has anybody seen any guideline that is different? NICE guidelines, ACC, AHA, Canadian, Australian. Okay. So here we divide or we categorize it into the gestational hypertension, which is less than 140/90. And they said in the measurement, try to measure at least two measurements within 4 hours. Sometimes I know at the clinic we do it several times just to make sure that we are sure of what we are doing, we are sure of what we are seeing. So taking the patients into consideration, the current setting, a lot of other things going on, if they are in pain and all of that plays into it. But greater than 140/90, gestational hypertension is one. Then mild systolic, for mild hypertension, they also actually mentioned mild hypertension, which is 140/149. I've seen some jurisdictions say stage 1 hypertension. So depending on the guideline that you use, you may see mild, moderate, severe, or stage 1, stage 2, and then hypertensive emergency or urgency. So 140/149, and then diastolic pressure 90/99 is mild, and typically that requires treatment. For moderate, 150/159 for the systolic, and then 100/109 for diastolic, and then for severe, greater than 160. And typically these are some of the yardsticks. One of the differences I found was that this is for pregnancy, but when you go to the NICE guidelines for the regular people, they do 140/159 and then 160 and above. So we should be conversant of that. The guidelines are a little different, so that we don't take what is for the average, me and you, and then put it to the pregnant woman. This is another important aspect, ambulatory BP monitoring. Many of the mothers or pregnant females, when they come and the BP is high. We put them on something, they go home, they take it 1, 2, and then BP drops. And they tell you, I have side effects. When I take it, I'm drowsy or walking around like a zombie all day. What is wrong with me? So ambulatory blood pressure monitoring is one of the very important things that we should always recommend for our pregnant mothers. Valuable for diagnosis and differential diagnosis of hypertension in pregnancy and follow-up. It helps. So one of the things we give out at our place is pregnancy diary or nutrition diary. So they come and I tell them, keep a diary. If you don't have a BP monitor, find a place you can check your BP or buy one and then give us feedback. It helps, especially when it comes to diagnosing chronic hypertension in pregnancy or gestational hypertension and then preeclampsia. Allows for detection of cases of white coat hypertension. I'm sure we know that one. Once they enter the hospital, the BP is high. They go home, it's normal. and they tell you, Doc, I swear, when I go home, the BP is okay. It's only when I come to your office, when I see your white coat, then something is doing me. Let me use the local language. Let me be yummy. So, and the nurses too. So, this is where it's very important. If they keep records, we're able to properly diagnose them. It helps us to predict preeclampsia, those that will get in trouble, and then late pregnancy prognosis and adjustment of treatment. And then, so we did mention white coat hypertension. They come in, the BP goes up. It's important to distinguish white coat hypertension from hypertension in pregnancy to avoid potential side effects. So they may not have BP, it's just that isolated incident. We put them on methyl dopa or labetalol or something else. They go home, they go and fall down because BP was 90/42. So let's watch that. Also, it also prevents unnecessary C-section or preterm delivery. So diagnostic criteria: severe systolic BP greater than 160 or diastolic greater than 110 on 2 occasions or at least 4 hours apart. I'm sure you have your protocols if they are not in there. So these are some of the things, but I know doctors, once they see anything above 160, they will recheck. Ask you to rest, they'll try a few things before to convince themselves that truly that is where you are and we need to manage you. Thrombocytopenia, so platelet count dropping to less than 100K, renal insufficiency, especially when you know their baseline creatinine, serum creatinine, and then it doubles or it starts rising steadily. Typically, that should ring a bell of, I use the word, raise your tentacles, that something must be happening. And then visual disturbances, they tell you, I see things tutu or blurry or something. Those are other things. New onset headache. Somebody doesn't have headaches, they get pregnant, and then all of a sudden, headache, they take their paracetamol, they take their brufen, they take anything they can take and it's not going away. Suspect blood pressure. Pulmonary edema, breathing issues. I work a little bit, I'm tired, I feel like this. Some of the patients will tell you, I feel like I'm swimming. My lungs are swimming, I can't breathe and all of that. Important things to always check the BP, look out for other tests. And then impaired liver function. So I strongly recommend monitoring kidney and liver in our patients. I know sometimes it's expensive, but once they go on medication, especially any patient you have those baseline things. Because for most medications, we pharmacists look at those things. That one, the weight, kidney function, liver function, and a few other parameters. So please, let's try. And then we did mention HELLP syndrome in one of the other, on one of the other slides. So increase in ALT, AST, platelet count dropping less than 100K. So HELLP is associated with an increase in maternal morbidity and mortality. And once you start seeing some of these things, start monitoring, keep a close eye on them because you can lose them so quickly. And then the other thing is when they come in, they have nausea and vomiting. And so somebody will ask you, but usually a pregnant woman, first trimester or first few months, they already have the nausea and vomiting, and they have this, what do you call it, morning sickness and all of that. So how do I distinguish? It could possibly be a new onset. So one of the questions that I will ask is this a new onset? Was it there before? This nausea and vomiting, in 50% of the cases, was it there or not? So let's always watch out for that. There's another thing that we can look out for is the right upper quadrant pain and generally not feeling well. So drug use principles. What are some things to consider when it comes to prescribing medications for pregnant women? We can't talk about medicines or how to prescribe them without talking about teratogenicity. So anything you take in can have an effect either on the mother or the baby or can be neutral. So when I counsel a pregnant woman, I tell them anything you take, know that 3 things can happen. It can hurt you, it can hurt your baby, or it is safe. So choose the best option, which is it is safe. If it's not safe, don't take it. Unless really, really, really need to be on it. So teratogenicity is the ability of a drug to cause fetal abnormalities or deformities. And that includes our supplements and our herbal supplements. Sometimes we don't think about it, but very, very key things. So teratogens are defined as agents or factors that cross the placenta causing abnormalities in our kids. So some baby will be born and there's no ear, no nose, or cleft palate, all of those things. It is what you did while you were pregnant. So they may directly or indirectly cause structural or functional abnormalities in the fetus or the infant after birth. And the response is based on exposure. Sometimes number of medications, environment, how long they were exposed, and all of that. So we should always be cautious. We should always look out for some of those things. We should think for the patient. So there's also, we all know about these phases of human development and how medicines affect those phases. So the first 17 days, pre-embryonic phase. And that's during this period, exposure to a drug results in either the survival of the intact embryo or death. So it's more of an all or none syndrome. That is why it is very scary for some people when they have been on certain drugs and then all of a sudden you find out they are pregnant, boom. And if they are on something that can affect the baby during those 17 days, then as a physician or as a nurse or as a nurse practitioner or PA, you start sweating. I'm sure doctors can attest to that. And they catch something, they say, no, I need to take you off this one quickly. So we should watch out for some of these things. First 17 days, all or none, and the pregnancy that's when miscarriages happen. So we should be cautious of those things. When they come, during our screening as nurses or physicians, watch out for what they are on, and if it's teratogenic, let's move it. The embryonic phase, from the 18 to 55 of fetal development. This is the period of greatest vulnerability of the embryo because you are forming so many of the organs and the systems and everything in the body. So if something bad should happen to the child, any bad deformities, this is where it happens. The fetal phase, from gestational age to 8 weeks, to gestational age of 8 weeks to term, so till delivery. The vertebral cortex and glomeruli continue to develop and remain susceptible to damage. Functional abnormalities such as deafness can occur. So the last part is where some of these things happen, and drugs that cross the placenta can affect fetal development. So anything you want to prescribe, let's check and see. Is this going to hurt my patient? Anything you want to give, always look out for the patient, look out for the child. I'm sure we know these ones, right? The FDA drug risk classifications. I'm sure we've all seen it, or we haven't. How many of you don't know about this one? Drug category A, B, C, D, and X. All right, so we'll go over this. So basically, every medication has this classification. It's classified into one of these areas. And when we prescribe drugs for our pregnant women, these are some of the things, we consider this as number one. So for category A, adequate and well-controlled studies have failed to demonstrate a risk to the fetus in the first trimester of pregnancy, and there is no evidence of later trimesters, which means the drug is safe. So category A, you can give it, you can give it and go home as a doctor and sleep, not thinking about lawsuit tomorrow. Category B, animal studies have failed to demonstrate risk to the fetus, and there is no adequate, but there's no adequate and well-controlled studies in pregnant women. So at least A and B typically we say are quite safe. CS, animal reproductive studies have shown an adverse effect to the fetus, and there is no adequate and well-controlled studies in humans. But potential benefits may warrant use of the drug in a pregnant woman. Sometimes they come. you know that in animal studies, they saw something. But the things that are going on with the pregnant woman, you must give this drug. And that is where the physicians go into their closet and start saying, okay, to give or not to give. And that is what, so basically that is where you go to give or not to give. And if the risk to the mother, you need to save the mother's life, that typically you will have to give it. Category D, there is positive evidence of human fetal risk based on adverse reaction data from investigations or market experiences. Typically, I will not give. When I see it, I'll call the doctor back and say, Doc, this one I beg you. And then let's see if there is another alternative. So D and X. X says that studies in humans or animals have demonstrated fetal abnormalities and there is positive evidence of human fetal risk. What are some of those medications? Who can tell me one? Category X. It's like, don't give. ACE inhibitors. Yes, go.
I've forgotten the drug that was marketed under the name of Contergan, and I've forgotten the generic name, but it caused amelia or things like that.
Oh, okay.
In the 60s.
In the 60s, oh, is it? It's not thalidomide. No, thalidomide, no. So Doc is looking up the name for us. Another one is our ACE inhibitors. So anything else that you think of? So while Doc is looking it up, we'll go to the next slide and then we can come back. All right. So prescribing principles in pregnancy, what should we look at? What should we consider? So drugs should be prescribed in pregnancy if and only if expected benefit to the mother is thought to be greater than potential risk to the fetus. So if we have to save the mother, we'll share some of these slides, so if you need it, I can give it to you. So prescribe only if necessary. Anything from even antibiotics, they can react to them. Over-the-counter stuff. I have a cold. A lot of these cold remedies have things that the mother cannot use or can be injurious to the child. Let's look through, let's read the ingredients. Always carry out risk-benefit assessment on an individual patient basis. So don't generalize it. This drug can fit anti-mansan, so I think anti-area, so let's give it to her. No. Do individualized assessment because everybody will be different. People may have different conditions, may be on different medications, may have different settings. So let's be very individualized in the care and in our assessment of our patients before prescriptions are issued out. Work in collaborations with the mother, ensuring that he or she is informed of any known risk or benefits taking the medications. Now lawsuits are coming left and right. Let them know the options. When you take it, this can possibly happen. It doesn't mean it will happen to you, but you may experience this. So that they don't come and say, next man can't share me. And I went to take it and now my baby looks like an elephant. So I'm suing. So please, let's share information. If you are not sure, you can go and look it up. But have patient leaflets or have something that you can give to the patient. That I'm prescribing this to you, and these are possible things that can happen. But per clinical guidelines, I think it is safe for you. If you see anything weird, quickly call me, and we'll see what we can do. There is more. As much as possible, all drugs should be avoided during the first trimester, which is a period of greatest susceptibility because that's when they are forming the brain, the spinal cord, the arms, legs, organs, everything. So first trimester, if you can avoid anything, let's avoid. However, it's always not possible, right? So, and that is why we are here. Only use medicine when it's absolutely necessary. We've talked about that. Use the lowest effective dose for the shortest time. That also is another thing to minimize exposure to both the mother and the fetus. Lowest effective dose possible, shortest possible time. So read the guidelines, the lowest dose that can help them. So we don't jump from the top. Maybe, oh, this infection is heavy, let me hit hard. You hit hard, the drug will also escape to the placenta and go and kiss the little baby. So it's possible. But and the other thing, I have one term that I use: start low and go slow. In our setting, sometimes we see BP 160/105. Then the medicine that they're supposed to use for the drug, they go to the highest dose. Let me knock it off. But if we can start low and go slow, that helps. Consider non-pharmacological treatment. So if you can use the non-medication remedy, let's try that first. That's in short. Let's consider older drugs, because that one we know the experience. We've tried them, we've used them, we know how they work in people before, rather than the very, very new ones. Because the newer medications, newly approved, they say, oh, this is innovative, this is novel, it's working but they haven't tried it in a pregnant woman. So let's sometimes, if you have the option of using an older drug that will work, try that one first. Absence of information does not simply imply safety or lack of risk to the mother. There are times that you look up, at the end of this slide, I also present some of the resources that you can use as references. There are times that we go look up information on the drug and it tells you no data. No data means it can be safe or it cannot be safe, but you don't know. And typically, I always say, don't treat blindly. So if you are not sure, look for an alternate source, unless that is the only option you have. Avoid known human teratogens, that one we know. So anything that's going to help or hurt the baby or the mother, let's avoid it. When considering treatment for unfamiliar diseases, always seek advice from a specialist clinician. So it doesn't hurt to go consult. For me, I like consulting. I'm a specialist, but I consult for malaria because in America, malaria was like this. But in Ghana, it's big. When I came back in 2013 after my training, I didn't know how to treat malaria. But bring the heart patient, take me to open heart surgery, I'll sort you. Take me to any infection, I'll sort you. But malaria, I didn't know Coartem. And people were laughing at me, so I'll call somebody and say, Charlie, Coartem, what dose do you give? I have a pediatric patient, how do I dose Coartem? We all don't know it. So you can call a friend and say, Charlie, this one, I know you are the guru. You praise them small and then they'll give it a apple. And you are happy. And you've saved the patient. Even within your own circles, some nurses are better than in certain things than others. So you can go and consult. Actually, I know that this area, you are the best person. Charlie, what do you think? All right. And you don't insult them and say, Charlie, your head die. All right. Let's move on. So avoid polypharmacy. We did mention that sometimes multiple medications increase the teratogenicity. So if you can use one agent, rather use one than two or three. I know sometimes it's impossible to just use one, but try to use a minimum number of drugs, and then you keep the baby safe. Offer pre-pregnancy counseling to all patients with chronic medical disorders. They should know, especially when they are on different medications when they come. Do counseling for them. Do a good check before you continue the antenatal care. Monitor any chronic medical conditions during pregnancy, because that is when there are so many changes in the physiological state of the patient and even the medical condition. So we should do a lot of monitoring for those. Close monitoring is what I usually would say. And then absence of information does not imply safety or lack. Okay, this is a repeated slide. Provide adequate contraception to women of known teratogenics. So when a woman is planning to get pregnant and they need to be on something that can cause problems for the fetus, provide adequate contraception, provide adequate counseling for them. Then accurate medication reconciliation is crucial at transitions between care and wards. Very, very important. Transition between the care, even from one side to the other, transition from the ward to home. Medication reconciliation is a big deal. And what is medication reconciliation? What were they on before they came to the hospital? What are they going home on? Or what were they on at theater recovery before going to the ward? Let's reconcile everything. No duplicates, no missed doses, no medicines left behind, so it's basically just doing your regular checks to make sure that everything is fine with regards to medications. And then herbal medicines and over-the-counter drugs should be included in your drug history taken. Sometimes we forget about that. Sometimes the patients do forget to tell us. But usually I go to them and ask them, do you have anything else that you don't consider medicine that you use? And they'll tell you, oh yeah, this cream or my uncle bought me this one. My auntie was using this and I tried it. And what does it look like? Oh, we bought it on a bus. Can I see? And so sometimes they come and they only bring their abrafundru, the medicines from the white man's country. And then they forget the Acobam and the other things. So always ask them, why do we need to do this? Are herbal medicines foolproof against teratogenicity? Yes or no? Do herbal medicines have side effects? Plenty. Half the time, even the way they work is just the same as a conventional medicine. They do the same thing. They are from the same source, except this one came from the root. It's just raw. It was somebody took it to their garage and did what they had to do to give you the juice. And then the factory man will take it through all the nice processes, purification, and produce the same drug and charge you more. But we should let them know. Herbals can also complicate everything and lead to side effects. Control underlying diseases such as arthritis. Those are simple things. Keep abreast with medicines and healthcare products regulatory agency alerts. FDA occasionally will issue an alert saying, we've identified this thing with this drug. Please watch out or withdraw it. Try to keep yourself abreast with some of these things. So OTC and herbals contain ingredients that can cause harm. We've mentioned this one. Medicines given shortly before term or during labor can affect the baby. That one too, I'm sure we know, right? Or we don't? Yes, petidine, morphine, some of the antibiotics, anything that can cross the placenta into the baby can affect the baby. Long-term smoking, the alcoholics. How many of you have seen pregnant women that actually drink? You've admitted them and they come and they are drunk. Sometimes we don't believe it, but it can happen. Smokers. Yes. So these things, counseling is so key. And in your settings, you should have programs that can help them either minimize or quit smoking. So there are a lot of smoking cessation programs. You can look into some of those things. Alcohol, and then so fetal alcohol syndrome and all of those things, they do occur. So it just goes on to talk about effects of alcohol, drinking alcohol and smoking. First 3 months of pregnancy increases risk of miscarriage, premature birth, and then intrauterine growth restriction, fetal alcohol syndrome, increased risk of spontaneous abortion. And these are some of the things we can tell the woman that, look, this is what you're going to do for your baby. This is what smoking will do to your baby. This is what drinking alcohol can do to your baby. Do you want to give birth prematurely? Do you want to lose your baby? Do you want your baby to come out with these things? Growth development problems, memory, and all of those things. Learning disability. And then they go and sit and think about it. You give them the option, they'll come back and say, okay, doc, I think I want to try and quit. And then you help them quit properly. Monitor for drugs that have narrow therapeutic index during pregnancy. Aminoglycosides. unfortunately, we don't do a lot of therapeutic drug monitoring in Ghana. Not enough. I wish we do. And I hope we will work on that. Oh, and then this one, the last part one. Consider maternal contraindications and precautions when advising on drug use in pregnancy. Avoid recommending labetalol for hypertension in an asthma patient. This is important. So just because guidelines say you can use nifedipine in pregnancy means nifedipine, every pregnant woman qualifies for nifedipine. Somebody may come and then they have pedal edema or a type of heart failure, and nifedipine may be contraindicated. So a simple example is the asthmatic patients. Giving beta blockers in asthmatic patients will worsen the asthma. In some patients, not everyone. So that's a classic example. So even though the drug is on the guideline, it doesn't mean that you can use it. So we should always look for contraindications. So live vaccines, I'm sure this one too we know. Your rubella and varicella vaccines should not be given to pregnant women. And then for certain drugs requiring body weight calculation, so like your aminoglycoside, gentamicin, and a few others, low molecular weight heparin, your Clexane, and so forth. Always use the dose at the time that the patient presents. So sometimes they come and then we record the weight at the beginning of the antenatal care. So when we have to give anything that is weight-based, that is where we go and look. Weight of the patient changes throughout the pregnancy, so we should always look at the weight at that particular time so that we use the proper weight in calculations. Bear in mind that sometimes it is not the actual weight that you need to calculate the dose of the medication. There are some medications that use what we call the dosing weight. So, and those have calculations which you can look out for. Then women should take folate supplements. That one, I will leave it out because I leave it to the physicians too, so that it doesn't become like every woman you see that is pregnant, take your folate and go, or folic acid. During our STG development process, we had a debate about if folic acid should be 1 milligram versus 5 milligram in Ghana. That one will be for another platform, because what we've known globally is 1 milligram, but Ghana we have 5 milligrams. Folic acid supplementation helps prevent neural tube defects. So, and we use 5 milligram in Ghana. Doc, right? Everybody in Ghana is 5 milligram. Anna. So I think I'll just leave it here. I'll leave it to the bosses to decide what is best. But globally, most of the global guidelines do recommend 1 milligram for the first 12 weeks. But then if you're at risk of the neural tube defects, then you go to 5. So there are some people that will need aspirin, either low dose aspirin or, and then the British guidelines do recommend 75 to 150, and then US recommends 71 milligram to about 150 as well. So there are certain people that will require the use of aspirin, and that also I'll leave to the doctor. So I won't go into too much detail on this one. The use of mark sulfate, this is standard practice in Ghana, especially for our eclampsia patients. And we've had issues from the pharmaceutical side. Recently there were some shortages, but I think it's coming back into town. So mark sulfate, one of the key drugs, and one of the priorities of treating preeclampsia is to prevent two things: prevention of seizures or complications, and then to control the hypertension. For seizure prevention, magnesium sulfate is the drug of choice, even though you can use other options like phenytoin and co, but this is number one. It's the safest. It has a lot of clinical data to back it up, safety and all of that. I'm sure the nurses have been trained in how to give it. So that also is one of our options. Preeclampsia complications, myocardial infarction, stroke, acute respiratory distress, and so forth, renal failure. We've talked about that. We should always look out for it. guideline recommendations for management of hypertension. Treatment depends on 1, level of blood pressure, age of gestation, occurrence of symptoms, and the risk factors. So to manage anybody, these are key things to look out for. Not that they've come in there, high BP is 170/110, so, and yeah, let's start. But we should always look at them globally. I use the word global, so have a very good, thorough assessment of everything before you start therapy. Non-pharmacologic therapy is recommended for pregnant women with mild to moderate hypertension in pregnancy who do not meet pharmacologic therapy. So if they do not, usually I always say if you can prevent medications early, so typically you should go with the lifestyle measures. And so weight loss, exercise, proper diet, some rest, and looking out for the root cause of the hypertension. Usually when you take that out, you're able to fix the patient without medications or treating to cover up what is happening. And then the last comment says, lifestyle modifications such as salt restriction and strict bed rest are not recommended by WHO. What it just means is don't recommend that alone. So don't go and tell them, oh, you like eating salt, and okay, from today on, I'm taking all the salt from your house. You can't cook your rice with salt. You can't, and truly, salt, eating a lot of salt may increase BP. But don't tell them stop eating salt and rest alone. That is what the guideline is saying. Add the exercise, add the proper diet, the other things that will, so that it's a package. So here again we have two guidelines. United States is saying that first-line treatment for hypertension in pregnancy, methyl dopa. And we use a lot of methyl dopa in Ghana, right? Is it our number 1? Doc, which one? Which one? Labetalol. Nifedipine. Okay, so Ghana is nifedipine. UK is labetalol. US is methyl dopa. So just have that appreciation for the fact that depending on the jurisdiction where you are, the guidelines can change. These are all drugs that are good. I'm sure before US just took this as number 1, they did their clinical studies and reviews and said, okay, this is the guy we like. UK looked at it and said, oh, methyl dopa, question number 3. Go to number 3. And then Ghana too, we say we like nifedipine. The Ghana nifedipine, that one too, we have a challenge. We don't have the 10 milligram sublingual or the immediate release. So docs, what do you use? 30, is it the 20, the retard? Yeah, nifedipine. Yeah, 30 sustained release. But I've seen 20 retard, which is used twice a day. Yeah, it's available. I think it's a Denk brand. But usually I see 30 milligrams. But I've gone to some settings where they were crashing it. Yeah,
We use the short release, which is the 20, plain nifedipine, 20 milligram.
So there's a plain nifedipine 20
yes, plain
on the market.
nifedipine, 20 milligram.
Okay.
You take it for 5 doses, making it 100 milligram, right? Yes, making it 100 milligram. So after the 100 milligram, if the BP doesn't calm down, then we move to labetalol or maybe hydralazine. If it doesn't calm down, then we move to another one. But as we are giving the short release, then we are giving the extended release too, which is the Nefecad XL, which is 30. But if there is no plain nifedipine, then we give the Nefecad XL 30, we crash. The coating makes it extended release. But once you crash it, the coating removes and make it short release. That is why we crash sometimes.
Thank you. So I haven't seen the immediate release nifedipine, so that is why I wanted us to discuss this among ourselves. We're all in the setting. So I've seen retard. And retard is not immediate release. It's a modified release, which means it will work over 12 hours. And in drug development, the modified release tablets and extended release or sustained release, it is not the coating that makes it extended release. It comes with sometimes a mechanism, or sometimes actually embed certain things within it that helps you release the medicine over time. So for example, Nifecad XL 30 does not contain 30 milligrams nifedipine. It releases that amount over a period. So if you crash it, you probably are crashing 120 milligrams nifedipine. That is why sometimes when you give that to a patient, you notice that the BP is 160 or 180, all of a sudden you are at 110 or 90. So that is why I wanted us to bring this up so that we can all educate ourselves. Crashing anything extended release or modified release, typically you may end up overdosing the patient. So it shouldn't be done. I'll look for the nifedipine 20 immediate release. If it's available, I think it will be a plus for us because a lot of the guidelines do recommend it. And it will help acutely to bring the BP down. But for me, if it's that high, I would rather go with an IV where I can titrate, connect them to a monitor, and know that I am seeing results. It's not every setting that is available. You may go to maybe Aflao people, they don't have the monitor to hook and then program it for every 15 minutes, check BP for me. But where you have the setting where you can monitor, IV labetalol, IV hydralazine, excellent choice. The other tip on that is don't start with high dose because they drop very big. 5 milligram hydralazine, you wait 10-15 minutes, come and check. Another 5 or 10. It saves you, I use the word, it gets you out of trouble than hitting them hard and then going to calm down, and then now you have to start giving IV fluids to resuscitate, and the family is standing there like this. They are killing my family member for me. And then you two are sweating because you hit them hard and they are going down. So for me, let's start low and manage. I use the word manage. Let's manage the hypertension than just treat it. So UK is saying that US first line methyl dopa, second line labetalol tablets. We do have labetalol tablets in Ghana. So if it's well indicated for the patient, they can be used. We look for side effects, so possible fetal growth restriction, neonatal hypoglycemia with higher doses have been seen, and then possibly bradycardia in some patients, but if it doesn't happen, I think labetalol is a very excellent choice. Few side effects. Methyl dopa, very good drug, but when you start at a high dose, the compliance rate drops. So if they'll be with you at the clinic for some time, you can start at a lower dose, give it time, it will work. The Philippine 30 to 120 orally once a day or twice a day, slow release formulation, it works. And it's our number one in Ghana. Hydralazine also comes in tablets, comes in IV. So some people will do well on it. Most of the pregnant women will complain about rebound tachycardia, both with the nifedipine and then hydralazine, because they are vasodilators. They open up the blood vessels. The heart is going to start beating quickly to make up for the vasodilation. So when you start it on them and then they come back and say, oh, now when I go home, I feel like palpitation, but it could be it. Sometimes that goes away. Sometimes it doesn't. With nifedipine, one big side effect, ankle edema. They come and they say, oh, I feel like now my legs are getting heavier and I'm developing edema. When that happens, you can actually switch to a different agent and they are fine. So let's take note of some of those things. Contraindicated, don't give ARBs. So angiotensin receptor blockers or angiotensin receptor, ACE inhibitors, so angiotensin converting enzyme inhibitors. And then you can also give, so the US people are saying that you can give hydrochlorothiazide, which is a thiazide diuretic in some people, especially where they have some type of edema or can help. But the NICE guidelines are saying they don't recommend because sometimes in the preeclampsia patients, they are also intravascularly dry, even though the BP is high. And so you further increase the chances of developing kidney failure and other things. So we should watch out for. So know your patient, have a proper assessment of your patient. Severe hypertension, so that's greater than 160 of the systolic and greater than 110 of the diastolic. Options include oral nifedipine, which we've mentioned, IV hydralazine or labetalol. Treatment should be started as soon as possible to prevent side effects such as renal failure, stroke, or congestive heart failure or myocardial ischemia. So here are your doses, 5 to 10 milligrams IV or IM, then 5 to 10 milligrams IV every 20 to 40 minutes, maximum total dose of 20. Or you can also do a constant infusion if you have the perfuser or the infusion pump. I like them. ICU people, we like infusion pumps because you want to put you on it and see how things are going and then see the BP coming down nicely. So, and then the nifedipine, 10 to 20 milligrams orally if you have the immediate release. Repeat 20 milligrams if needed, or 10 to 20 milligrams 6 hourly, maximum dose of 180 milligrams. So reflex tachycardia and headaches may happen. Starts working in 5 to 10 minutes. That's the crashed one. Labetalol IV, start at a low dose and then slowly titrate up. So 10 to 20 IV, then 20 to 80 every 10 to 30 minutes. Maximum cumulative dose is 300 milligrams. Or constant IV infusion. We've done that. We do that at my facility a lot. And then starts working in just 1 to 2 minutes. So it's a very excellent drug, but watch out for bradycardia, or if they have cardiac issues, then not the best drug to give. If they have asthma, not the best choice. So this is the NICE guidelines from the UK, and that is what they are also saying. So first line, labetalol. Second line, nifedipine, modified release. So they didn't even go for the immediate release. Then third line is methyl-dopa. And then fourth line, consider IV infusion if severe hypertension or in the critical setting or critical care setting. So they were using doxazosin tablets, which is an alpha blocker. I was quite shocked, but I'm sure they have their data to back it up. Labetalol infusion, hydralazine infusion. It tells you when to avoid and who to not give. And then it also tells you if it can be used in breastfeeding. So labetalol can be used in breastfeeding, and then your methyl-dopa and then nifedipine can all be used in breastfeeding mothers. So post-delivery also, these are good to know. Then postpartum, labetalol and nifedipine may also be continued once daily, but once daily options preferred. So this is just for us to some quick review on the guidelines. I'm sure there are other things we do in Ghana that can help us. So some drugs to avoid. Diuretics, ACE inhibitors, ARBs should be avoided in pregnancy. Diuretics deplete already reduced intravascular volume seen in preeclampsia. So that is their reason to not use a diuretic. But if the patient is well hydrated, adequate volume, you may use it short term. And then ACE inhibitors and ARBs cause fetal harm. And then if a patient is on this before they become pregnant, switch them to safer options. And then typically for every patient who has hypertension and is pregnant, they do recommend home BP monitoring. The role of the pharmacist, the last few slides. So we have to make sure you have medicines. I know that some of the facilities, you go and then they write a prescription and give it to you, Kokotobra. My facility, we don't have that. And I always charge my colleagues that, look, there are some things you must have. The patient shouldn't go out and get it. In a life-threatening situation, you need magnesium sulfate. That is not when you write a prescription. Pharmacy, do you have it? Oh, no, we are short. So we must have the drugs ready at all times, either for the nurses, either in your unit, in your emergency cart, it should be there. Provide counseling on drug-drug interactions. We typically, for me being a clinical pharmacist, I look at every patient from head to toe. I do consultations, I do a lot of things. I look at, you come and you bring me a prescription, I'll screen you from top to bottom, including what diseases you're on and everything before you get your drug. So typically we're supposed to, I call myself the support person to the clinical team, the doctors and nurses. I'm the last line before the medicines will leave. If I make a mistake, we're all going down. So I have to do that work. We counsel patients on the importance of following up with providers, blood pressure monitoring, lab work, and all of that. Contribute to hypertension management. So we try to be part of the team in managing hypertension. So when you need something, it's not that now that you're going to look for me. So coming on ward rounds, working closely with you. Thankfully, where I work, I have access to everything, including what I call all the nursing notes, lab information, physician notes. I also put in my pharmacy care notes, so everybody sees what we do. So if I need to call a physician, Doc, I beg, I've seen this thing. Is it possible we do it this way? I want to recommend this. And we work very closely. If Doc needs something, he will call me. Since I've been here, I've had 2 phone calls from ICU. So we work so closely. So working closely actually saves the patient's life than everybody being there somewhere. Then provide pre- and post-pregnancy counseling for women. We do a lot of discharge counseling. We do a lot of counseling for our people in the hospital. So here are some of the things that we do. At the community pharmacies, they have the BP monitoring stations, the medicines and everything. So let's work together to save our people. Some obstacles, knowledge gaps. Without knowledge, you can't manage your patient. If you don't know, you don't know. But if you know, you know. And usually you chest out and say, oh yeah, I'm going to knock this one out because I know I can fix the patient. Where I come from is like pride to know that you know. So we always do our best to know everything about, especially where we work. If you are in an obs and gynae setting, make sure so being. The nurses, the patients and the doctors should know that my nurse, if I put something in their hands, they'll deliver. The doctor should come and know that this case that has come, oh, hey, Coco, will ace it. So knowledge gaps bring problems because sometimes they come and we don't even know how to manage them. We don't have enough information about the condition. So let's grow our knowledge. Let's increase our knowledge. Global supply chain issues. I mentioned the max sulfate issue. There's a lot of drug shortages, especially in the Ghana Health Service settings. But at least make sure what your patients need, they have it. Drug shortages, protocols. We have so many protocols, we have so many guidelines in the country, but they are in people's closets or offices. Dissemination sometimes is poor, but we have them and we don't follow up. One of the things that helped us in the US, where I used to work, I brag about it because we were a top 100 hospital in the whole world. And we had doctors who developed their own medical procedures. So everybody came to learn from us. But everything we did, we had a checklist. So when you pass through, you are seeing the patient, have I done this, have I done this, So you cross you dot your I's and cross your T's, which helps you, that checklist helps you stay true to everything you do. So if you work with those type of protocols, it is difficult to make a mistake. It is difficult to miss anything. So if you don't have those things, start looking for them. Somebody can Preeclampsia protocol. Have we done X, Y, Z? Have we checked this lab? Have we done da? Have we given this medicine? When was it given? How soon? And at the end of the day, you can look at it and say, okay, we did well. So for us, that was one of our big things. And the pride of the thing was that we tell ourselves we should not lose the patient. So anybody that comes, don't lose one. When we lose one, it's like we didn't do our best. And then people will go and stand in the corner and cry. So I've seen doctors cry, I've seen nurses cry, I've seen a doctor, like, his whole day shuts down because he's lost a patient. So let's start thinking some of those things. No pharmacist on the multidisciplinary team, so we don't know what the problems are and be able to help solve them. There are some too that are there and they don't even bring themselves. They are my colleagues, so I can talk to them like that. Then health facility related issues, equipment and supplies, consumables, staffing, and all of that. These are some key challenges that we can all identify. Anything else that you can think of? I know there are many. Yes, sir. 5 minutes. Okay. Actually, I'm almost done. So that's basically, and then national guideline dissemination challenges. Guidelines are not getting to people. And then these are resources you can use for references. There are databases, there's Medscape, teratology information services, mother to baby. There are so many websites you can use for both medication and then for disease references. So, in conclusion, preeclampsia is a threat to maternal health and survival. Access to prenatal care, early recognition and detection of risk factors is very important. We should monitor our people well. Hypertensive disorders in pregnancy are killing a lot of people, and we should, try as much as possible to minimize and then do well and manage the patients. We are an integral part of management of hypertension in pregnancy, so involve us, please, and thank you. So, any questions or comments?
Thank you very much. I want to appreciate you for the presentation. My question is on polypharmacy. In relation to a particular condition, let's use the preeclampsia or maybe hypertension as example. We know that as you go higher in terms of dosing of medications, the side effects increases. So if you are treating, let's say, hypertension or preeclampsia, and you are using a single agent, what do you recommend? Do you hit the highest dose before you introduce a second agent, or you may want to add a second agent if you are not getting the results, instead of going to the highest dose for the first agent, knowing that the higher the dosage, the higher the side effects?
It will depend on a few things. So it will depend on if it's maybe category A, FDA category, where there's no risk to both the mother and the child. You can probably go higher and then monitor for side effects than adding on. Where you think even going up another 5 or 10 milligrams will cause side effects, then I'll probably look for another agent. But it's how well the patient has done or has fared on the current regimen that will determine a lot of things, and the safety to the fetus. Yep. Anything else? Okay, there's another one.
Please, I want to find out if, per chance, you have an idea why we are having challenges with getting the plain nifedipine.
Yes. So, plain nifedipine was one of the key drugs that we used in hypertensive agencies. But later on, there were so many clinical studies that showed that even just that 10 milligram, giving it to a patient who has a systolic of 190, you could drop to about 110. And so the side effects, the adverse effects on the patient, people were actually developing more severe symptoms from just giving the 10 milligram. So they took it off every guideline for urgency. And once you take a drug off a guideline, it affects how many or how much of it people buy. So the companies that produce it also stop manufacturing. That is why it's not available. So it's more of a guideline thing, and the fact that we're seeing more adverse effects from it than. So I think our time is up. So.
Unless there's a final question from the crowd. No, if not, then please.
Oh, okay. Okay, all right. Oh, we do have people online, so I wanted to appreciate the people online. I want to thank you for your attention. If you have comments or questions, you can still send them in the chat box or in the Q&A. So we have. Yep, so we have 4 people online. So thanks for joining us. We are really grateful for your time. If you have questions, any comments, please go ahead. And
Please, let's give Dr. Mark one more round of applause. I think he's done an amazing job. Yeah. And again, in honor of being a speaker for this symposium, and the wonderful things you do for our patients, as well as our pregnant women with severe preeclampsia, APEC Ghana wants to present you with this citation. But I think the whole group might want to agree that they want to give the citation, so I would recommend everyone get up and let's all come in front. And we'll be taking one group picture with the citation. So we've been sitting for long as well. So let's all get up and let's all come together for one final picture. So you will stand in front with it, okay, if you're fine with it, and then you're there. Is the camera this way? Okay. Mr. Munya, I want your picture. Energy, answer. Yes.
Tomorrow, same time. Tomorrow will be extraordinary.
Please come and join us.
Me?
Oh, yeah, come and join us.
Oh, you know, I'm sure you are seeing that I like behind scenes.
Today you stand in front.
Okay. Okay.
Thanks to everyone who makes salutes. Hello. Hey, by the way, this was my lecturer. She taught me.
I work as a quality assurance. So my day job is quality assurance in one of the pharmaceutical companies as well.
We're trying to set up a quality assurance. Okay. We're new. We are 5 years old.